So the next lecture is by Dr. Bargman, the 10 common mistakes in the management of lupus nephritis.
Thanks very much. So over the years of managing lupus, I've started to come up on some recurrent themes, and I decided to distill them into this talk, which is actually a paper published in the American Journal of Kidney Diseases. And interestingly, it's one of the most downloaded papers from that nephrology journal. But if you want to read what I'm talking about, you can just PubMed me in the American Journal of Kidney Diseases, and this paper will show up. So I'm going to talk about the first mistake. I'm going to be spending a little more time on this compared to the rest, but I really do want to emphasize, do people here use cyclophosphamide for lupus and lupus nephritis? So again, it's this idea that if a drug is toxic, it must work really well. I told you about the cough mixture, and a lot of the studies came from the National Institutes of Health, pictured here. And in fact, if you look really closely, it seems like the NIH has this giant experience of cyclophosphamide with lupus and lupus nephritis. And in fact, many of these reports are the same patients, just being like an 18-month follow-up, a 24-month follow-up, and so on. So it makes it look like a bigger bulk of literature than it actually represented. But I want to go back to one of the early studies of cyclophosphamide, only because I think it still teaches us a lot of lessons. This was published in the New England Journal a long time ago, and it was a randomized controlled trial of prednisone alone versus prednisone and a daily oral cyclophosphamide. So this is before the pulse era. And what they found in this study was that both groups, prednisone alone and prednisone plus daily oral cyclo, had the same degree of improvement over the first 6 months, which comes up to a point that I keep repeating, that in fact it's the prednisone that, as Dr. Fortan said, puts water on the fire. It's the drug that acts the fastest right away. However, the prednisone-only group had more renal relapses, but the addition of the daily oral cyclophosphamide, a powerful immunosuppressive regimen, did not improve the initial response rate. In other words, the initial response depends on the prednisone. And another point that I think is more appreciated by nephrologists than by rheumatologists is that people that have advanced disease, with like a baseline creatinine of 2 or 3 and a lot of fibrosis, end up with end-stage renal disease no matter what you do for them. So I think those are the lessons. It's the corticosteroids that work the fastest, but just because it works, don't get lulled, as I've seen this happen, into deciding not to give a second agent because the patient's done so nicely on just the corticosteroids. Use a second agent, but you don't have to do this right away. And this is certainly what I see in places where I practice, where someone comes in with acute bad lupus or a really bad flare, and everyone feels, I've got to put them on the second agent like right away. I can't wait until tomorrow. The second agent is really more of a long-term disease-modifying drug, and there's no overarching urgency to get them on that second agent. And again, let me just emphasize that people that have a lot of established renal damage don't tend to do well no matter what you do for them. Now I want to talk about another paper that's probably one of the most quoted papers in lupus nephritis, also published in the New England Journal, which is the NIH protocols. And this is just, again, an interim report of 5 different ways that the National Institutes of Health treated lupus nephritis. And you can see the 5 different protocols there. The most recent one was the intravenous pulsed cyclophosphamide. That was like the new kid on the block. And when you look at the results, this is the sort of a renal survival curve. And this is, to their credit, this is out to about 160 months. So that's like 10 plus years. So this is one of the first long-term studies of lupus nephritis. And the first important point is that the prednisone alone group did the worst. And then there was no statistically significant difference. But if you look at this, the intravenous cyclophosphamide did the best. So if you didn't read this paper, if you didn't do anything else, and you only looked at this picture, which is what I think many, many people did, you'd say, well, look, I mean, obviously the best result is with the intravenous pulse cyclophosphamide. But first of all, people thought this was a randomized controlled trial of 5 different ways to treat lupus nephritis. It wasn't. It was just different studies over time, different times of follow-up, and in fact there was no statistically significant difference. There was between prednisone alone and all the other groups, but all the other groups sort of fell in the same way. And part of that was because there were a vanishingly small number of patients that were left in the later time of the trial. I've written there the number of patients that were still at the end of the trial in each of the groups. So we're talking about tiny number of patients, and people didn't realize this when they saw this intravenous cyclophosphamide at the top of this renal survival curve. I showed you this before. This is, we're talking again about cyclophosphamide, just again to emphasize, because I think no one before me has emphasized this, that the so-called low dose versus high dose cyclophosphamide that showed that so-called low dose did just as well. In fact, after 3 months, these patients were being managed by azathioprine. And there's no mention of that when people discuss this study. Whenever they mention this study, they just say it shows that low dose works just as well as high dose cyclophosphamide. So really for years it was just held as in stone that if you're going to induce someone with lupus nephritis, you have to use pulse cyclophosphamide. Then starting in the 2000s, the envelope started to get pushed a little bit. This is a study from Hong Kong where they looked at prednisone and daily oral cyclophosphamide switching to azathioprine, or prednisone and MMF. And this was shocking because no one ever dreamed that you would even consider inducing someone with lupus nephritis with something other than cyclophosphamide. And in fact, the 2 groups did the same. Again, you can make a point in the first 12 months, maybe it's the prednisone effect that we're seeing. And then the people who make MMF got involved in a series of first American and then international trials comparing MMF to cyclophosphamide. And again, they were short-term studies. Do you see for this one, the duration is 24 weeks, which is 6 months. And I showed you in that old study from the New England Journal that in fact in the first 6 months, the prednisone alone group did the same as the prednisone and daily oral cyclophosphamide. So in fact, this could all be the effect of the prednisone, and maybe that's why we're not seeing any difference in the second agents. But interestingly, probably adding a second agent does increase your risk of infections. And here's the different infections. The cyclophosphamide is in gray, and you can see if you look at the severe infections that in fact in the cyclophosphamide group it was worse. This is pulmonary infections. The cyclophosphamide was worse than the MMF. This is another part of those trials that was published in the New England Journal. Again, showing, again, it's a short study, and I fault it for that, but you can see certainly the patients that were induced with MMF did no worse than the people induced with pulse cyclophosphamide. The numbers are small, but certainly they did no worse. You could see if, in terms of renal failure and death, you'd want to be in the MMF group rather than the intravenous cyclophosphamide group. So they thought that MMF in their hands was superior to pulse cyclophosphamide, and they again advanced this outrageous proposition that maybe you could do induction treatment in lupus nephritis with MMF just as well as you could with pulse cyclophosphamide. And as I said, no one really had the nerve to undertake an induction study with steroids and azathioprine. So again, sponsored by the group that made MMF, they did more studies, and I showed you this in terms of the under-response of people of African origin, but really there was no difference in these kind of criteria, even by race, except for a particular under-response in blacks and Hispanics to the cyclophosphamide. Now, I'll come back to this, but the most interesting part of this particular study isn't that MMF and cyclophosphamide work the same, but if you look at the rate of complete remission at 24 weeks, It varied, it didn't matter what drug they got, between 8 or 9%. And to me, this is the most important point. If you're going to remember one thing from today, from me, it's that it takes a long time for people with lupus nephritis to get better. And one of the mistakes is that people are worried that after 2 months, there's still blood and protein in the urine, and they decide to escalate therapy. And that is where everyone runs into trouble. So this just shows you the remission rates by the different renal criteria. And again, if you look at the number that were in complete remission, by 6 months, it was vanishingly low. Or in other words, over 90% of patients were not in remission, renal remission, by 6 months. So that's the first issue, is around cyclophosphamide. I hope that you will reconsider that there's very little evidence, there's no evidence that it should be the drug of choice for all patients with lupus nephritis. The second big problem I see is that not enough attention is paid to the dosing of corticosteroids. A lot of people think that you treat this like you treat an asthma attack, and you give like a high dose of prednisone for a couple of weeks and get them off the drug by a month. In fact, the current standard of therapy is 1 milligram per kilogram body weight, or even pulse solumedrol, as we talked about earlier, with a slow taper over 6 to 12 months. And I lean more to the 12-month plus. And very often we nephrologists, I don't know about rheumatologists, are so focused on, should I use cyclo, should I use rituximab, should I use MMF, whatever, that they forget about the dosing of prednisone. And again, prednisone is crucial for this. It's the thing that brings the disease under control the fastest. And in fact, the sooner you bring the disease under control, the less opportunity for lupus-related organ damage. And the KDIGO guidelines also emphasize the importance of corticosteroids in the treatment of lupus nephritis. And I must say, one of the commonest phone calls I get is from someone that says, oh, I've got a patient with lupus nephritis and I used MMF and it's not working, probably because I haven't waited long enough. What should I use next? With no mention of the prednisone, how much and how long. It's like, it's just not on people's databases, and it's a very crucial part of the treatment of the lupus nephritis. Now, this is something that the rheumatologists have all over the nephrologists, and that's the use of antimalarial drugs. In fact, if you're a patient with lupus and you're treated by a nephrologist, you have half the chance of being put on an antimalarial drug than if you're being treated primarily by a rheumatologist. And as Dr. Fortin alluded to this morning, the results with antimalarials, I just summarized to the residents. I say it's all good. Everything that's looked at antimalarials in lupus has been good in terms of flares and, you know, all the usual indications, but in terms of flares, including renal flares, thrombosis, organ damage, you name it, it's all good. So there's an overwhelming reason to put patients on antimalarial drugs, and I probably don't have to convince this audience, but I'll just tell you it's not on the radar screen for nephrologists. And I just, Dr. Fortin alluded to this study by Roman this morning and about what were the risk factors for developing plaque versus no plaque in long-term lupus patients. And one of the factors, at least statistically, that seemed to be associated with not developing plaque was the concurrent use of antimalarial. And interestingly, the patients, this is a side point, the more prednisone they use, the less chance of developing plaque. And I think that all has to do with trying to control inflammation. And again, you can get this free on the internet. We've written a review of the role of antimalarials in lupus. Again, this is probably more important for my fellow nephrologists than for rheumatologists, but it summarizes all the studies with the antimalarials and how very important they are for the treatment. Now, the next mistake is using the urinalysis as a response index, and again, I think the rheumatologists are so keen on this. These previous panels that looked at outcomes will even use the number of red cells and red cell casts as an index. And I've actually heard someone said, well, last time they had 10 red cell casts, now they've got 5 red cell casts, they're getting better. That's crazy. If you've ever done a urine yourself and you spin it and you decant the supernatant, how hard you bang on the test tube and how much of a drop you put on the slide all affects the number of red cells and anything you see in the urine. It's not that scientific that you can quantitate casts. So this is really a pseudoscience, and I think that the rheumatologists are coming around to this too and realizing it's going to be coming out of subsequent response criteria for the treatment of lupus nephritis. Furthermore, the urinalysis can continue to show blood and protein like for a really long time. That doesn't mean that you have to treat the patient for a really long time. It may just be part of what they have, and sometimes you just have to live with it. So it takes a long time for this to get better, and there's also something called residual proteinuria, which may be a little bit of damage to the nephron from a previous attack of lupus nephritis, or it may be very mild ongoing disease. Neither of those are indications for therapy. Again, the hardest thing sometimes is to do nothing. But if there's just a very small amount of protein, I'm talking about less than a gram, we just basically ignore it. The most important thing is to not escalate immunosuppression to treat the residual proteinuria. And this just came out, and it really supports what I have to say. It looked at the urolupus cohort, and it looked at how do these different urinary parameters predict long-term outcome. And I've always said that the two most important things is the degree of urinary proteinuria. I'm not talking about residual proteinuria, but just, 6 grams or whatever, and the serum creatinine. When they looked at red cells and outcome, it actually reduced the predictive value of the urinalysis. It was just so all over the place that it really had no relationship to renal outcome. And I think we're going to see this idea of number of red cells and red cell casts and everything eventually disappear from kind of the renal outcome index. Now, this is something that just came to me as a major revelation. And let me just take you a little bit into nephrology. So, we have to deal with lupus membranous. There's obviously also a primary membranous nephropathy unrelated to lupus. And no one really understood what it's all about, but the causative antibody in about 70% of the cases has been found. And that's this antibody to the phospholipase A2 receptor. No one knows what that means. No one knows what phospholipase A2 has to do with anything. But certainly patients that have primary membranous, about 70% of them have got antibodies to this receptor. But the important point I want to bring up is that in primary membranous, if you treat patients immunologically, for example, with rituximab or something like that, you see the antibody levels go down to 0 at a time when there is still nephrotic range proteinuria. In other words, you treat the immunologic problem, but there's a lag time until the proteinuria gets better. And usually people, if they see that these antibody levels have gone down to 0, they'll stop treating and they'll wait for the proteinuria to resolve. So this is an example of what I'm talking about. So here's the level of antiphospholipase A2 receptor. Here's a patient that gets some sort of immunologic treatment like rituximab or whatever. Here's the antibody levels going down. And when they're undetectable, there is still significant proteinuria. Okay, but the levels are 0, so you wouldn't keep hammering at this person immunologically just because there's still proteinuria. It takes time for the proteinuria to get better. Okay, here's just the same thing. This was a particular study with rituximab, and again showing that at the time when the causative antibody became undetectable, there was still significant proteinuria. It takes time for the basement membrane to heal itself or repair itself or whatever it has to do. And it struck me that this is what's happening in lupus nephritis, especially in lupus membranous. It's not the antiphospholipase A2 receptor antibody, but it's some other antibody that we haven't discovered yet. anyway, you give the patient your the prednisone or whatever else you're going to give them, and probably what's happening is that this antibody is in fact disappearing or getting better, but there's still proteinuria. But because we're not measuring whatever this is, all we do is we keep seeing proteinuria, and that's when people want to switch therapy or give rituximab or switch to cyclophosphamide or whatever, because there's still proteinuria. And that is why it's important often not to keep hammering away with the immunosuppression if the only reason you're doing it is that the person still has proteinuria. Sometimes the best thing is just to wait and see what happens. And this just recently came out from the Toronto lupus cohort, and it looked at the time until 24-hour urine protein normalized. And you can see it takes time for this to happen. In fact, the worst one was membranous lupus. And please look at the x-axis to show you that, we're talking here out at like 5 years. Okay, we're talking in terms of years, in terms of the resolution of the proteinuria, not anything like 24 weeks or 3 months. Okay, and again, this is available, this is a study from Italy where they also looked at resolution of proteinuria, and this here is membranous lupus. And you can see that slowly over time, the proteinuria normalizes, but look, this is 15 years. So we've got to reset our minds in terms of the time it takes for the basement membrane to heal itself, and not feel that just because someone's got ongoing proteinuria that we've got to give them ongoing intensive immunosuppression. The next mistake is not scaling the intensity of the immunosuppression to the intensity of the disease. As we talked about before, most people feel that mesangial lupus, low-grade proteinuria, microhematuria, doesn't need treatment. Probably people with membranous who have like a gram or 2 of proteinuria, you can watch and wait. And certainly class 6, which is sclerosing, kind of damaged kidneys, there's no indication for immunosuppression there. Now, what about this issue of membranous lupus with nephrotic range proteinuria? I told you about this morning when I talked about the KDIGO guidelines, and KDIGO does recommend adding a second agent, but I'm not so sure about that. I've certainly seen patients treated with prednisone alone who go into remission and stay in remission and don't need a second agent. So I think this whole question about a second agent for the membranous variant of lupus is up in the air, and there's no studies. I showed you this study from Brazil that showed that patients with membranous lupus did just as well on prednisone alone versus prednisone and a second agent. So this is my approach to lupus membranous. With subnephrotic proteinuria, I use an ACE inhibitor or an ARB, although, as I mentioned this morning, I don't know if it's doing any good for these patients, and certainly if they're hypotensive or they have a systolic blood pressure of like 100, I'm very happy not to use it. But anyway, you just observe them. And then with nephrotic range proteinuria, I do use modest doses of corticosteroid. You can add cyclosporin or tacrolimus. I don't think this treats the proteinuria on an immunologic basis. I think it treats it because it causes pre-renal vasoconstriction, which mechanically lowers the amount of protein that leaves the glomerulus. So I think it's kind of like an ACE inhibitor or ARB, just more expensive. And something else that wasn't mentioned in any of the guidelines, but I think is so crucial, and Dr. Fortin alluded to it this morning, is that if someone's got significant proteinuria, they are in a hypercoagulable state. And I don't think these patients should be on estrogen-containing oral contraceptives. Even if their APLA-ACL is negative, I don't think they should be on oral contraceptives, because I think that's an unacceptable risk of thrombosis. And I just talked about the OMS this morning, so I'll skip that. This is a very important thing, and again, it doesn't seem to cross people's minds. And this is about so-called treatment failure, and forgetting that I think the commonest cause of treatment failure is that the patients don't take their treatment. So, this, as I say, the cruel joke about lupus is that it affects young people, especially women who are so sensitive about their looks anyway, and then you give them this mainstay drug that just changes how they look. So I think even in young people, getting them to adhere to medication that doesn't change the way they look is hard enough. And then you add one that gives them hair and acne and big cheeks and everything like that. And I suspect that non-adherence is much greater than we even dream about. So KDIGO guidelines has got, they say, oh, if the patient's resistant, try an alternative agent or switch to this or switch to that. And there's nothing about talk to the patient or call the pharmacy. I don't know if you can do that here, but we can call the pharmacy and find out when the patient last filled their prescription to find out if they're taking their medications. So, I think if someone's got a lupus or a lupus flare and you prescribe high doses of prednisone, you should see the complements start to come up. You should see the hemoglobin start to come up. As I said, you can't look at the urine sediment, but you should see this kind of stuff happening. And if it's not happening, think about whether, in fact, they're not taking their medication at all. If they're not looking Cushingoid at all. And the other thing I find, too, is that if your patient theoretically is on 40 milligrams of prednisone, and prednisone comes in 5 milligram tablets, that means every morning of their life they're counting out 8 tablets of prednisone. So if you say to a patient, well, how many tablets of prednisone do you take every day? And if they start doing the arithmetic, trying to figure it out, then they're not taking it. Because if you're counting out 8 pills every morning, you should be able to say 8 right away. So, these little tricks, but I still think there's loads of people who aren't taking their treatment. So how do we increase adherence in this population? I really, I don't know. And I think part of it may be my fault, and that is that many patients aren't told that lupus is a life-threatening disease. If someone is diagnosed with cancer and walks into our cancer hospital, they know they're in for a rough time, they know their hair's gonna fall out and, everything, because they've got a life-threatening disease. I don't think people do that with lupus, us doctors. I don't think people realize the gravity of lupus. And so you just say, you've got lupus, take this medicine. They take this medicine, they get some side effects, and go, whoa, and they stop it. So maybe we have to have I know we don't want to bum the patients out, but maybe we need to have more of a, lupus is like cancer. And I tell my patients that you don't have cancer, but you have something that's as potentially serious as cancer, and that's lupus. And maybe that will make them tolerate the side effects more, the way people tolerate the side effects of cancer chemotherapy. I alluded to this before, but not reducing immunosuppression in people with advanced chronic kidney disease. As I said, a nephrologist knows that if a patient has a new baseline creatinine of 3 or 300, that the ship has sailed, they've got extensive damage. And if they have yet another renal limited flare, you really have to weigh whether it's worth it to give this person a whole load of more immunosuppressive agents. So, this is why I'm saying that you've got to think about whether it's worth treating these patients. Really, at the point where their creatinine is 3, you should be doing more like end-stage kidney disease, dialysis and transplant planning than anything else. Dr. Fortin alluded to this before, but there's a lot of side effects to the immunosuppression. We're always so engaged in the MMF versus rituximab kind of thing that we forget that there's a lot of housekeeping that has to be done for these patients, including eye checks for not only antimalarials, but for steroid-induced changes, bone marrow density, and that's why I like doing my clinic with a rheumatologist, because I let them worry about the DEXA scans and things like that, and lots of other side effects to the immunosuppression. And this is also from the lupus cohort, which looks at damage in lupus, just to say that really in the long term, the major accrued damage, this is musculoskeletal and ocular, were probably more an effect of the treatment of the lupus than the lupus itself, avascular necrosis, cataracts, and so on. So we have to be cognizant of that and monitor these kinds of things. I said I'd come back to the renal biopsy, and this is something else I can't figure out. So a patient comes in, there's no question that they've got acute lupus, either brand new lupus or a big flare. You know, they've got everything going on, and in addition, they've got blood and protein in the urine. And people seem to be so intent that they have to have a renal biopsy at that point. And really, how insecure do you have to be? If someone comes in with acute lupus and they've got blood and protein in the urine, they've got lupus nephritis. And if their creatinine is up, then they've got bad lupus nephritis. So you know what the diagnosis is. And it's probably going to be a high-risk biopsy because very often these people are hypertensive as part of their acute lupus, and that increases your risk of bleeding after renal biopsy. If they've got an elevated serum creatinine, we know that the bleeding time goes up, so they've got another risk for bleeding. And of course, if they're thrombocytopenic. So it's a high-risk renal biopsy, and you should never do a high-risk renal biopsy in the face of an obvious diagnosis. Or we get this too. Someone presents with lupus and has a life-threatening extrarenal manifestation, such as pneumonitis or cerebritis, for which they're going to get intensive immunotherapy anyway, and they've got a little bit of blood or protein in the urine, and we get asked to do a kidney biopsy. And the point is, if you already know you're going to give this person intensive immunotherapy, why put them through the risk of a renal biopsy at that point? So when should a patient have a kidney biopsy? Really, it's probably more not to start immunotherapy, but to cut back immunotherapy. So again, you know, if you think the lupus patient is getting better, but they still have nephrotic range proteinuria, you don't know what's going on, again, I would probably wait. But you could do maybe a renal biopsy then, just to make sure that it isn't all sclerosis. You know, if the creatinine's going up for some reason and everything else in the lupus is getting better and you have no idea what's going on, or if the patient is antiphospholipid antibody positive and you want to see if this is renal thrombotic microangiopathy versus classic lupus immune complex renal disease. But in theory, that's a good reason to biopsy. In reality, often these people have a platelet count of 20,000. So it's going to be a very high-risk renal biopsy. Oh, and they're on heparin. So it's going to be a very high-risk renal biopsy. And then let's say someone's got also diabetes, and then they develop proteinuria, and you don't know if this is lupus membranous versus diabetic nephropathy. Something like that might be a reasonable indication for renal biopsy. But someone presents with acute explosive lupus and has renal involvement, I don't know why people feel so compelled that they have to do a kidney biopsy at that point. And then lastly is to forget to address pregnancy. And this is an example from this children's hospital. Someone comes in with bad lupus nephritis and is treated with steroids and MMF and is doing better and comes to the following up clinic. She's so happy and she says, guess what, I'm pregnant. I'm going to have a baby. And because no one ever told her not to, okay? So you know, your nurse knows that having a pregnancy during acute lupus or right soon after lupus or taking teratogenic drugs is not a good idea. And there's a lot of teratogenic drugs that we give the lupus patient. But the patient may not know. That part of her life may be completely just disconnected in her brain to the lupus part of her life. So it's really important that you have counseling with the patient and tell them you can't get pregnant now. This is very dangerous, you know. She might not even care about herself, but you're going to say, you know, you'll lose the baby or the baby will have multiple birth defects or something, but you've got to tell them before they get pregnant that they shouldn't get pregnant until their lupus is under control. So these are the 10 things I want to talk about. I hope I've convinced you that cyclophosphamide is not the gold standard. Pay a lot of attention to the corticosteroids. Again, people don't seem to do that. You rheumatologists know better than us nephrologists about the importance of antimalarial drugs. Don't use microhematuria, CAS, or even proteinuria in isolation as a response criterion. It takes a long time for these things to get better. Scale the intensity of the immunosuppression to the intensity of the disease. I think non-adherence is gigantic, and we need to be better at educating our patients at the potential severity of lupus. And, if someone's having yet another renal flare in the face of established renal damage, think about it, maybe even discuss it with the patient, but think about whether it's even worth it trying to fix this and expose the patient to yet more immunosuppression. You don't have to do a renal biopsy in the face of an obvious diagnosis, especially if the patient is at high risk. And don't forget to counsel about pregnancy before the patient gets pregnant. Thank you very much.
Yes, we have time for one or two questions from the audience.
Again, thank you very much for the talk. Now, for the first five, which is the most annoying, I would say.
Yeah, it is annoying.
Our practice. You mentioned about the improvement of proteinuria over several years or more, and we have to be patient with the patient for a long time. Now, treating this patient, and you emphasize the idea about giving steroids is the major player probably, and the other ones may not be that good because we don't have good evidence.
Exactly.
Now, we start with the treatment of corticosteroids, and then you're waiting for a long time. And what would you do with the steroids? Because you have to do it for a very long time, and a lot of our patients really hate us because of that, because they don't like to take steroids for that long time.
So that's why I was trying to make the analogy to the primary membranous, is that just because they have proteinuria for a long time doesn't mean that you have to give them steroids for a long time. You're probably treating, I don't know where it is, you're probably treating immunologically whatever you're treating, you've done the right thing, and then you have this lag time until the proteinuria gets better. So as long as they continue to show proteinuria, it doesn't mean that you have to continue to give them significant corticosteroids. I don't think so. If everything else is quiet, people with lupus membranous very often don't have any other extrarenal manifestations. It's really just the proteinuria. I think, like I said, the hardest thing sometimes is not to do anything. So I would treat with these modest doses of steroids, maybe get them down to 5 or 10 milligrams by, a few months, 4 to 6 months. Maybe, I don't know the right answer, maybe keep them on 5 milligrams for the next year or so and see what happens.
5 milligrams, I guess, is a dose that does not usually cause nutrition.
Right.
Now, my other question is about cyclosporine A, because this is, I'm sure that most of dermatologists don't use it that often.
Yes.
What I learned,
Yes.
really don't use this drug for more than 2 years. It's really very bad drug to use for a long time because of the renal insult, because of the gingival hyperplasia, because of many other things. Now, I saw your slide about saying that you might need to use this drug for a long time, at least 8 years. And I don't know what you meant about that. How many years do you think?
So, as I said, I don't think cyclosporin treats lupus immunologically. I think it's a good way to try to reduce proteinuria, kind of like an ACE inhibitor. And because of that, we tend to use 1 to 2 milligrams per kilogram instead of the usual immunologic dose is 5 to 6. If you look at people with renal transplants, they get like 5 to 6 milligrams per kilogram of cyclosporin, and that's where you run the risk of the cyclosporin nephropathy. We're using much lower doses here because we're trying just to reduce the proteinuria. So I'm less concerned about the development of cyclosporin nephropathy. And frankly, what I do is on that low dose, if the creatinine starts going up, I just stop the cyclosporin and see if it comes back down again. But otherwise,
How many years do you usually use it for?
2, 3, 4 years. Yeah, and I do that with my primary, especially cyclosporin only works for as long as you use it. We know that like from minimal lesion disease and other primary glomerular diseases, that it reduces proteinuria, but in over 90% of people, when you stop it, the proteinuria comes back. So you really need long-term low-dose treatment. And like I said, I don't think you're fixing the problem. You're just kind of controlling the problem by changing the hemodynamics in the glomerulus.
Waiting for the glomerular
Right, to get better. Yeah, exactly.
Can you just repeat the question again? Yes.
So ongoing proteinuria, if we're talking about subnephrotic proteinuria, is not in and of itself an indication to switch drugs or increase drugs. And even the KDIGO says that too. Live with it. Okay, if we're talking about like 1 gram, something like that, yeah, live with it. Don't switch medications just based on that. If everything else is better.
We have to hear this from you probably several times until get stuck to all that, because we're facing this all the time.
To switch? So again, if we're talking about renal related, because of course there may be extrarenal stuff going on that you also have to decide your immunotherapy. But if we're only talking renal related, the two important things that mean that something's going on is if the creatinine goes up and if the proteinuria increases. And I'm not talking about like from 1.5 to 1.6. I'm talking about going like from 1.5 to 3, and the serum albumin drops more. Then I worry that this is either superimposed fibrosis, sclerosis, or there's membranous or something like that, and that I would probably re-biopsy at that point. But short of that, unless things are getting worse, if they're staying the same, don't switch therapy, don't escalate therapy.
Last question.
All right. Very commonly in our practice, we see patients, lupus patients who had lupus nephritis in the past, with a new creatinine baseline, mild proteinuria, and they want to get pregnant. What's the threshold renal function that will allow the patient to get pregnant?
So that's a great question. In fact, as Dr. Fortin said, we're very lucky that we've got a high-risk pregnancy unit, including a nephrologist who does high-risk lupus pregnancies. And I agree 100% that that patient should be referred to a high-risk unit, again, hopefully before they get pregnant, and get counseled about whether or not they should go ahead. Interestingly, most of the patients we've sent who have been told not to get pregnant don't get pregnant. If they've been told that. But I'll tell you that they want to see lupus inactivity for at least 6 to 12 months, protein less than 1 gram, and better yet, less than ½ a gram on 24 hours. And the creatinine is not that crucial. Do you use milligrams per deciliter here? Mm-hmm. Yeah. So, if the creatinine is like 1.2 or something, it's high risk, but they wouldn't counsel against a pregnancy just based on that. They're more concerned, in fact, about the degree of proteinuria than the serum creatinine.